Hello, everyone. Welcome to a new episode of Home of Medicine podcast with myself. Hi, I'm Ben Lovell. I'm a consultant in acute medicine working in London, and I'm also my sidekick.
Hi, Amy Burbridge, also a consultant in acute medicine in the UK.
I have a case for you, Amy. Amy's sneezing, but she's nodding at the same time to say, "Tell me your case." So my case is, I'm actually going to do this a bit differently. I'm going to give you the information that I got at the point of referral, because normally we do it bit by bit and then we work it out as we go along. But this is what the patient who was referred to me, a 64-year-old man. I need to refer you a 64-year-old man, please. We're treating him for an NSTEMI. He's come in with an abnormal trop. His troponins 40 and an abnormal ECG. This is actually with more epigastric pain, but he's got bilateral arm heaviness and tingling as well. Associated features with this is he's felt nauseated and he's vomited. And I told you his his trop's 40 and his ECG is abnormal. We've also done a D-dimer and it's 4,000. So we're going to get a CTPA as well, just to make sure that it's not a PE. But otherwise, we've already treated him with ACS treatment, but he needs to be admitted to medics. Is that okay?
Just to clarify, Ben, first, what's your cutoff for D-dimer in your hospital? Because ours is very different.
550. And his
Okay,
was 4,000. And our cutoff for troponin is 14, and his was 40.
okay. Thank you so much for that referral. So, first of all, you said there are some ECG changes. Can I just clarify what the ECG changes are?
Yeah, clear, biphasic, very abnormal looking T waves.
Okay, any ST elevation, depression noted?
No ST elevation or depression, no.
Okay, regular AF?
Regular sinus rhythm.
Okay, so just some T wave changes. Okay. You also mentioned some bilateral heaviness and tingling. Is this
Yep.
new?
Yeah, new, yeah, associated with this this more epigastric pain, yeah.
And when did the pain start?
So this has been going on. The patient's actually not from here. They're visiting. They're from Lithuania, so they're visiting their daughter here. But the pain and all of these symptoms started yesterday.
Okay. Did you do blood pressure in both arms?
No, I didn't actually. I've just got one blood pressure. I can do blood pressure in both arms if you'd like.
I'm just thinking because you mentioned epigastric pain, chest pain, bilateral. I'm just thinking of the aorta.
Oh
So,
yeah, we thought that as well. So that's why we're getting the CTPA,
okay.
CTPA and CTA. Because we thought maybe the high D dimer could be
Yeah.
related to a dissection as well.
Okay, cool. Okay, lovely. Thank you.
Will you see the patient? Brilliant. Thank you very much. So
Well,
that's the referral. And one of our fantastic resident doctors went and clerked the patient.
okay.
And the story was pretty much as stated. Since yesterday, so coming up to 12 hours now of epigastric pain, which could be in keeping with an inferior MI, as we know. So epigastric pain, with heaviness in both arms, mostly the forearms. The pain didn't radiate anywhere, it didn't go through to the back, and it didn't go up to the chest or up to the jaw. The epigastric pain. Vomiting's quite bad with this. It feels really nauseated with it and has been vomiting every couple of hours, at least since this morning, with biphasic T waves, which look very abnormal on the ECG. The patient did not have any past medical history and was visiting us from Lithuania, limited English. So this was done via their son and sometimes their daughter as translator. No regular medications to think about, no regular, no past medical history, as I mentioned. Smoker, 20 a day, lifelong. So that's the risk factor for a cardiac event, I guess. And some alcohol intake, but patient was currently retired and not working. That's the social history.
Okay.
Yeah.
So I just ask you a few more questions. You said some vomiting. Any diarrhea that you've known that's been noted?
No, that was not open since yesterday, actually.
Okay. Any right upper quadrant pain? I'm just thinking of gallstones.
The pain, well, it was sort of diffusely across the top of the abdomen. So there was some in the right upper quadrant as well.
Okay. And you said alcohol. Do you know how much alcohol he's been drinking?
I get the sense that it's a couple of units a day, but not much more than that.
I'm just thinking, could this be pancreatitis? You've got a raised D-dimer, which can
Oh.
also be consistent with pancreatitis, epigastric pain.
But Dr. Burbridge, the ECG and the trop and the D-dimer,
Yeah, I mean, D-dimer is non-specific, so that can happen in any sort
Mm.
of inflammatory event. Yeah, I see. But the trop, I'm not worried of a trop of 40. I'd like to get a repeat trop actually.
Oh yeah, we'll get a repeat trop as per protocol. Well, do you want me to cancel this CTPA then? If you don't think the D-dimer's okay.
That's because it's D-dimer is 4,000. So it's still, I mean, it's a lot higher than normal. Nothing to me here suggests a PE. However, we did talk about the bilateral arm heaviness, so I'm worried about his aorta, so I would like to image the aorta. I think that'd be really helpful because aortitis can sometimes present with forearm pain as well. I'm just thinking of some going back to my rheumatology days, I'm thinking, is this an underlying autoimmune inflammatory condition? Do I need to check an ESR, creatine kinase? I want to ask about headaches. I want to ask about GCA symptoms.
So no headaches. We haven't done a CK, but I can add it on if you like. What were
Yeah.
your other things you wanted to know?
ESR, please, would be helpful.
Oh, we don't normally do that, but we can certainly do. I've got his blood tests, is ones that we've done, if you'd like
Excellent.
those.
What's going on with those?
HB 150, white cells 16,
Yeah.
neutrophils being 14.5. Platelets were normal at
Yeah.
477. His
Okay.
sodium was 140. Potassium on the VBG, we're still waiting for the formal serum bloods, but we got the VBG results. Sodium is 3.1, but he has been vomiting a couple of times, at least in the department. We're replacing that with 40 millimoles of potassium IV. Creatinine's normal at 85. And the CRP, let's have a look. Oh, it was about 42,
Okay. Did you do a gas on this gentleman?
just a VBG,
And what was the pH?
7.36.
Okay, so it's within normal. It's a bit on the lower side, but it's within normal
Yeah,
living.
yeah.
Okay. So just his OPS. So
Okay.
oxygen.
So I've examined the patient. The blood pressure is 130 over 75. I've asked the nurse to do it in the other arm, and the other arm
Okay.
it was 128 over 80, so pretty similar.
Yeah.
Sats are 98 on room air, heart rate 70, and the temperature is 36.9, so that's all normal.
Mm.
Yeah, that's the vital signs.
So absolutely pretty normal. So my assessment then, A to E assessment you've just done for me. Does this gentleman look well or unwell?
He looks uncomfortable, to be honest, with the pain and the vomiting. Yeah,
Okay.
he's hyperventilating with the pain because it's quite bad.
And was the hyperventilation consistent on the gas? Did you see a low carbon dioxide on there?
Well, it was a VBG, so the
Oh, sorry.
CO2 is not
Yeah.
so useful, but it
Yeah.
was the normal parameters.
Okay. So things that go through my head here are number one, really need to manage this gentleman's pain and vomiting. So can we give him some antiemetic and also something for the pain as well? I think that would really help him. Now, I'm
Okay.
not convinced by the diagnosis of an NSTEMI. It's possible, but the level of the vomiting that he's having, I really want to think about, is this something more gastric going on in here? Is this an ulcer? Is this gastritis? Is this cholecystitis? Is this pancreatitis? So I'm not just going to go down that cardiology route. I want to go down other routes as well. And I think that sometimes happens when we're given a trot that's slightly high, we go, right, it's cardiac, but actually it might not be. So I want to be thinking about, yes, could this be cardiac? I want to repeat troponin. I'd like serial ECGs because you said there were ECG changes. You're going to do a CTA, which has already been requested and suggested. I'm going to give him an antiemetic. I'm going to give him some pain relief. I'd like to add an amylase onto the bloods as well. I'd like to do a CK. I'd like to give him some fluid. Blood pressure's okay, but if I'm thinking pancreatitis, they can get very dry very quickly. I'd like to do a glucose.
Okay. So I feel like up till now I've been sort of acting, and I'm going to step out of character and be Ben
Yeah.
again. I feel like I've been a referring doctor.
I quite like she was the acting Ben,
I
referring
want to be
doctor
me.
Ben.
I want to be me. So just to pick up on things that you said there. So before I give you all those lovely results that you want to know,
Yeah.
you're not convinced that this is what was presented, or you just think that you want to keep your options open.
You feel no, I guess not because there was some chest. It was more like an epigastric pain with a significant amount of vomiting,
Yeah.
with some also you mentioned to some upper abdominal pain as well, which can happen in cardiac pain, absolutely. But the Tropper 40 doesn't convince me, an isolated Tropper 40 doesn't convince me this is cardiac. I want to look for other things as well. So I'm not convinced, but I think that's our job as acute physicians to not be convinced and to not take everything at face value into question.
I think it's really interesting when what gets told to you as a presenting complaint, because sometimes it
Yeah.
doesn't quite add up. It's not rare that someone will say, so this is a patient who presented with ECG changes in Tropper 40, for example. And I think I very much doubt they came into hospital saying those words. That was what they presented with, unless they got a home ECG and blood testing kit. What did they actually come in with? Because I think that's quite important. And I think that I know why it's very tempting to present salient results right at the top of the history. But as someone who listens to a lot of histories, I kind of need to be guided down a road. And it's very different being a consultant, because when you are in training or when you're a more junior resident doctor, your role is to clerk patients and present them to a consultant. And one of the big switches I found going to be consultant is that I now switch into receiving mode. I have to listen to stories rather than use my own workup skills. I still do clerk patients myself just because I love it and I really enjoy doing it. But most of the time, I'm letting other people present their clerkings to me, and it's a different part of my brain. And so being told somebody presents with a blood result, this patient presented today with a potassium of 6.3. Well, hang on, they didn't really, did they? Why did they come in? Why did they come in? This patient came into hospital today with back pain, which has been going on for about 9 months. So why did they come in today? I'm not clear. What was their presenting complaint? It sounds silly, and it's right back to basics, isn't it? Presenting complaint, the first thing you sort of learn about how to clerk a patient. But I really like to know that, because I want to know why the patient came in today, what the symptom was that drove them to go through the rather unpleasant experience of checking into an emergency department and waiting to be assessed. I don't think people take that lightly. Is that familiar to you?
Absolutely. I think particularly because we see a lot of patients now, probably compared to what we used to, and particularly in same day emergency care, where we're doing rapid assessments, and somebody will say, I've had chest pain. They say, okay, so how long have you had it for? What is it about the chest pain today that's brought you to hospital today? Why are you here today? And they'll often say, well, my GP told me to come in, or I've had it for so long, I just wanted to get it checked out.
Mhm.
Has anything changed? What is it about this pain today that's brought you to hospital? And I think sometimes people look at me as if to go, why are you asking that question? But it helps me really understand and filter through what's really going on when you're seeing a lot of patients.
And for a similar reason, that's why I prefer not to have stories presented to me diagnosis
Yes.
first. So, I've got a quick patient for you, Dr. Lovell. It's a 24-year-old with pyelo, or can I present this patient to you? It's an NSTEMI. And, the voice in my head is sort of like, well, hang on, I'll be the judge of that. I'm sure you're right, but just go present it to me and then we'll come to it together. Because sometimes I have a flash of inspiration and I might think of something else it might be. Most of the time they're dead on, and I completely agree with it. But when you're a listener of stories and when you're receiving histories, you have to develop a way of processing the data very quickly. And the person who's presenting history to you can guide you down a mind line, as it's called, towards a destination, and you probably end up in the same destination. But I think you have to do it. I remember when I was in training, there was one consultant I worked with who preferred the other way around. He says, when you're presenting to me, present diagnosis and then present why that's the diagnosis. And I found that really weird. It was turning like a lot of training on its head and doing things in a very artificial way. And it doesn't work for me.
Yeah. What's really interesting as well is that one thing that drives me potty is prepping notes. So I was on the ward round the other day, and they were just like, oh, I'm just going to prep the notes. I went, there's no such thing as prepping notes. It doesn't exist when you're on my ward round. What do you mean? And to prep the notes? No, you don't. We review the notes together.
Mhm.
What is prepping the notes? And
I mean, it comes from I know that it comes from a place of being efficient and trying to be a
absolutely,
good
yeah,
team
yeah,
member.
yeah, yeah.
Really, but I exactly the same page as you. If I say to a doctor, can you see these three patients? And then I'll meet up with you in 45 minutes and we'll see them together. And all they've done is prep the notes, i.e., gone through the history and written a
Yeah.
little summary, but haven't seen the patient. That wasn't what I asked you to do. And that's not a use of your skills. I want you to be a doctor, not my secretarial admin support.
Mm,
Uh, and I want to read it together. And another thing that comes out of that is when someone's presenting a patient to me and they're reading the notes, presenting a history,
mm.
and I sort of look at them and I say, sorry to interrupt, have you met this patient? They're like,
Yes.
no, I've just prepped someone else's clerking and prepped the notes and I'm presenting it to you. I'm like, this has become very weird. Please don't feel you ever have to present a patient you've never met to
Yeah.
me,
Yeah, exactly.
creating some kind of a template from someone else's work,
Yeah.
because gosh, that's not what you came here to do today. And it opens us up to all kinds of thinking
Yeah.
errors and mistakes. let's go through it together and let's go and meet the patient
Yeah.
together and actually meet the patient. And so I'm very much on the same page as you with that. I think also the reason why people do it is because a lot of consultants do want them to do that. So
Yeah, and and that's okay if
yeah,
that's how they want to work. But I said yesterday or the day before, I said, have you seen the patient?
yeah.
No, well, could you actually physically see them? Because you're not going to learn anything by reading somebody else's notes. And the feedback is, I really enjoyed doing that. That was great. It was much
Yeah.
better. Like, yeah. And
So I
you're
guess what
learning
we're
something.
saying is if you're on Ben or Amy's ward round, you don't have to prep
You
notes, but
don't
we
prep
completely
notes.
appreciate you may go and work with another consultant who'll say, why in hell haven't you prepped any notes going on here? So you can't win. But that's just we come from a very similar sort of way, I think, of processing data and working out diagnoses in our heads, and that comes
Yeah.
from going through the story. So it's
And
that how the story
yeah.
goes.
What I've started to do now is say if I'm working with doctors I've not met before, I'll say, like, this is how I do my ward round. It's very different to how other people do them, but it would be good if we could do it this way. And they'll be like, oh, thank you. It's really helpful to know how you want to do it, rather than assuming that we all
Mm.
do exactly the same thing. Some people just roll their eyes at me and go, oh God, this is going to be a long day. But I'm like, it's fine. Well, I get a piece of paper now. So I did a couple of weekends ago. I gave the doctor I was on with a piece of paper and I wrote on the top things I've learned. And I said, right, you need to write down things you've learned. And the first question he had was, does tazocin have sodium in? And I was like, ooh, let's go and find out. Tazocin has 241 milligrams of sodium or something like that. Huge amount of sodium. So by the end of the day, we had a sheet of A4 of things that we both learned from that ward round on a piece
I
of.
think if I did that, my column of things I learned would probably be bigger than
Well,
the other
exactly
one.
mine was. I was like, I never
No,
knew that. I
didn't
never
know
knew
that.
so was
Didn't know that. Yeah.
exactly. So I'm on Sunday again, so I'm going to get my piece of paper and leave it around. But anyway, we're off the topic. We were going baback to our 64-year-old.
So yeah, let's go back to our patient.
Yeah.
So 64, and in summary, because everyone has forgot what we're talking about because we went down a little rabbit hole there. 64-year-old man visiting from Lithuania who presents with epigastric pain and bilateral arm heaviness, and associated with this, some vomiting, has vomited the potassium down to 3.1, I think it was, and important blood test results show hypokalemia, D-dimer of 4,000, and a troponin of 40. And that's where we're up to now. And the vital signs were normal, and we're waiting for more imaging. Shall I tell you a little bit about the examination findings? I've given you the vital signs. So chest was clear, heart sounds were normal, patient was in sinus rhythm, patient was uncomfortable and was breathing quite hard, and the abdomen was soft. There was no guarding or peritonism or rebound tenderness, but was diffusely tender in the epigastric region. It was tender there, not distended or tympanic. So what did you want? You had a little shopping list of tests.
I want the amylase.
Amylase was normal. It was 47.
Okay. I had plasma viscosity or ASR, which you said you didn't do.
I don't have that data, sorry. It's not
Okay, that's
something
okay.
I tend to do.
That's okay. And I think we're just waiting for the results of the CT angiogram, aren't we? The CTPA.
Okay, so the CTPA happened, no PE, no aortic dissection,
Okay.
lungs are clear. There is ascites. Is there a known cause for this? Question mark. I love it when a radiologist asks a question in a report because you can't really answer them, but it sort of prompts you to think. But that's what they wrote.
Ascites. Okay. So I want to ask myself the question then, going back to earlier on, I'm not convinced this is cardiac. I think this might be something going on in the gastric area, the abdomen. So let's go down the ascites. Liver function, is that normal?
Okay, so we go back and we add on some LFTs,
Yeah.
and they all come back as normal.
Okay. Is there definitely ascites there? Is another question as well. So it was a CTPA, wasn't it? A CT
Yeah.
angio. So wasn't specifically looking for ascites. So it's probably not the best imaging modality to pick up ascites. So,
Yeah.
questions.
So it was a CT, yeah, PA, as you say. So it picked up just the top of the abdomen, and that's where they noticed something that we hadn't particularly looked for, asked for. There was no shifting downwards or marked distension, so it wasn't moderate ascites on examination,
Yeah.
but it was a surprise.
So I'd question, is there any other signs of failure? So is there you said there was no fluid on the lungs, but is there any swollen ankles? Is there any signs of liver failure, but also unlikely because the bloods were completely normal, the liver function, clotting function, prothrombin time, INR?
We have all of those. INR was normal. There
Completely
was no
normal.
peripheral edema. The JVP wasn't raised.
Has he perforated something? Was this ascites or was it free fluid in the abdomen potentially? So I think it might be worth at this point, because of the vomiting and the abdominal pain, probably doing either an ultrasound scan of the abdomen or a CT abdo-pelvis.
Okay. Same route as you. Let's get a CT abdo-pelvis. This is
Yeah,
someone who's got severe epigastric pain, ascites out of the blue, and vomiting. It
yeah,
does point towards potential abdominal pathology.
yeah.
I'm being told there is a raised troponin, a raised D-dimer, and there is an abnormal ECG, which could be in keeping with ischemia. But maybe that's a secondary process to something pathological that's happening in the abdominal cavity. So
Did
is
you
there
have a headache?
headache, did you say?
Yeah,
No, why?
this is really obscure. Headache, ECG changes, vomiting, subretinal hemorrhage. Okay, it's really random. Let's
He
just
did not have a headache or
no.
tummy
Okay,
tap or
just
no.
pretend I've not said that.
No. So we do a CT abdo pelvis, and I've got the report. There is a long segment of obstructed ileum with mural thickening and a focal transition point. There is dilated loops of small bowel. There is inflammatory ascites. The patient has small bowel obstruction. Surgical review recommended. So
Yeah.
let's go back to the presentation.
Yeah.
I got told I've got someone here with an end STEMI with sort of epigastric pain and abnormal trop and abnormal ECG and bilateral arm heaviness.
Mm.
Associated with this, he's vomiting quite a lot and feels very unwell.
Mm.
The D dimer is 4,000 and the potassium's 3.1. Let's do this another way around. I've got a patient here with severe abdominal pain and vomiting.
Mm.
He's vomited so much, his potassium's fallen to 3.1. He's hyperventilating and has clenched fixed
Mm.
fists and tingling in his forearms. He, on his ECG, he has clear U waves in keeping with hypokalemia, and his lab potassium came back at 2.8.
Mm.
The D dimer and troponin are non-specifically raised.
So that's the framing effect, isn't it? It's how we are sold a patient, or how patients are sold to us, or how we sell patients. And the way that you were sold that patient was cardiac. And it's really difficult to challenge that cardiac diagnosis, isn't it?
I think also it makes me wonder if there's a hierarchy in our heads of organs or systems, and
Yeah.
cardiac goes at the near the top.
Yeah.
If someone says to me, I've got someone here with lower chest slash epigastric pain, abnormal trop and abnormal ECG,
Mm.
with associated with vomiting, that sounds different to I've got a patient here with severe abdominal epigastric pain and vomiting associated with some ECG changes and a non-specifically raised trop. But even that way round, I feel very commonly we say let's just look at cardiac first of all. No, is it
Mm.
written down that cardiac disease takes
Why
priority?
do that?
I think maybe because the heart is a vital organ in sort of common parlance and the gut isn't. I mean, people with chronic abdominal issues will disagree with that and
Yeah.
argue that, it's just as important. But I wonder if there is sort of an unspoken hierarchy of problems.
Yeah.
Like at the top, we say airway, someone's lost an airway or someone has an acute neurology, and then acute cardiac seems to go underneath that. And then maybe breathlessness, chesty things go underneath that, and then
Mm.
the poor old guts and under the bottom of the
The
totem
joints have
pole.
got no hope.
The joints, forget about it. Nah, least important at all. It's
Yeah.
probably reactive arthritis. We'll deal with it tomorrow, whatever whatever's going on. But
I mean,
you think
that's
that's
really good
true?
point. Yeah, I do. I remember I've said this probably on this podcast. This is another one of my sayings that I like to uh, talk about all the time is when we have an elderly patient who is confused, what do we say they have?
Delirium,
They do, but what's the cause of that delirium?
UTI.
But it isn't, is it?
No,
So, and we don't dip the urine of anybody over the age of 65 unless we think they've got an intrinsic renal problem. But anyway, I say that every week. I'll just say it again. However, what we don't do is we don't try and identify causes of delirium, one of which might be a septic joint, one of which might be an inflammatory arthropathy, polymyalgia, joint arthritis. We leave it so far down the examination list that often it's not done.
I think a lot of that is to do with heuristics. So we tend to go down the easiest pathway because it's the most common thing to happen. And where time is an extremely finite and, in fact, scarce resource, we do want to reach for common rules of thumb, previous mind lines, known heuristics, and say this is commonly what causes this particular condition. So statistics say that's what's going on today. That's all the time I have to think about this. So that's what we're going to do. And I've got to move on to the next situation because I'm experiencing a lot of workplace pressure to move on and get numbers done, to get quantity done. And I think, and most of the time, these heuristics, these mental shortcuts, they do serve us well. They exist for a reason, but it does ignore the minority of patients who don't present in classical ways that do need a bigger think. So atypical presentations, they sometimes don't do so well. So we need to find a way to work out how we can use mental shortcuts and heuristics in our clinical practice, but not actually shortchange people who have got a slightly atypical presentation of a common condition or a very typical presentation of a very uncommon condition.
I think the first step in that is an awareness of our own heuristics and how we practice. So we need to undertake metacognition. We need to think about thinking, and we need to think about our own thinking, because the way that you think and the way that I think will be different. The way that when I'm on call on Sunday, the way that I think will be very different to the other consultants I'm on call with. I have to be aware of how I think and my biases and my shortcuts. And I think that's the first step in a lot
It
of.
is really interesting because how do you do that? I guess the way you do that is by asking and asking other, for example, let's ask another consultant, what
Yeah.
have you noticed that I do? I'm not asking for praise, I'm not asking for criticism, but what have you noticed I do? The blockage to that is we don't work together, consultants.
I know.
We're lone wolves,
Exactly.
we are
Yeah.
the consultant on course. So who can I ask? I can only ask the resident doctors I work
Yeah.
with. They are not comfortable feeding that back to me. There's a hierarchy at play
Oh,
there.
some are.
But as lovely as I am, and I strive to be, I can appreciate why I'm not going to get really honest feedback.
Yeah, that's
If I
true.
said to an SHO or Reg that I work with, saying, what have you noticed that I do? I'm interested in learning and growing
Um,
and developing as a consultant, metacognition, etc., etc., etc. What have you noticed that I tend to do? Because I find that really valuable. I feel like I'm putting them in a really tricky spot. I'm going to stress them out and they're going to struggle to say anything
mm,
honest because they'll always be thinking, is this going to be impacting on me? Is this going to be any blowback here? I don't feel like I'm psychologically safe to be giving feedback upwards to a consultant like this. That's how I would have felt. So the only people who could probably give me some decent feedback, I think, feel quite inhibited to do so. I do know some hospitals who do a consultant peer review just once a year, where you go on a morning walk down with your colleague, and at the end you give very non-critical, but just feedback on things you observed. I notice that you tend to do this. I notice that you like doing this. I notice you ordered this test a few times, and this. I have absolutely no judgment with this at all, but this is me just telling you things that I see that you do. And I think that I only saw that happen in one hospital I trained in, and we just don't have the time. If someone said to me, Ben, can you spend a morning shadowing Amy on her ward round and then just give us some
that'd be good
observation
fun.
feedback? I'm like, when the heck am I meant to find a free morning to do this? It's
Yeah,
I don't
maybe
have a
we should
morning.
do that, Ben. Maybe we should come and watch each other do a ward round. That'd be that'd be quite.
Yeah. You'll probably be horrified. Like, Ben, you spent 4 minutes in that room. I would have spent 4 hours. But I think that it would be a really good
Yeah, it would be.
thing if
Mm,
we had the bandwidth for us to do as consultants. And then thinking about the other doctors, resident doctors, we're always observing them and giving them feedback because
yeah.
it's part of their training and the portfolio and all that sort of things. But we're not saying that when you're a consultant, you don't need it anymore.
I would love somebody to do a consultant to do a ward round with me and observe me and say to me, Amy, maybe you can do an LP sometimes. Your rule of never doing an LP is absurd. Amy, maybe you should do an echo occasionally. That's okay. I think I'm aware of some of my faults. I think there are a lot more. It'd be really interesting to see what they are. And I'd love a consultant to watch me on a ward round and to give me feedback that would be helpful.
So I guess to our listeners, be you consultants, someone in a training post, residents,
Mm.
ACPs, PAs, whoever, how do you know what you do? How much insight do you have into your own practice, your own heuristics, your
Mm.
own sort of mental shortcuts and biases that you have? How are you aware of how you practice?
Yeah.
And let us know, because we'd love to learn from you as well.
Yeah. Because we can, I mean, a lot of mine probably comes from self-reflection, which is how I started on this whole bias podcast route. Thinking about it, like 10 years ago was when I made a mistake, and it was about reflection and why I made the mistake. But I probably don't reflect as much as I used to, because I just don't have the time to reflect as much anymore, because clinical work's much busier, home life is much busier.
And reflection is inherently biased. You could only know what you know, and you
Yeah,
can
that's true.
reflect to death on a situation, but you can only do it within your limited perspective of that situation.
Yeah.
And guided reflection, or asking someone to help you with reflection or listen to your reflection, which is what we do here a lot, is sometimes the only way of looking at things in a slightly different way.
And
Yeah,
often the reflection is very negative.
critical, yeah.
We very rarely on this podcast go, we've done a few sessions where we've gone, I did this great diagnosis, but it is often quite critical reflection.
My only final thought about that was that whenever we get a lot of feedback where people send us emails and etc., it tends to be on an episode where we have been quite critical of ourselves.
Yeah,
We
that's
talked
true.
about a mistake. And
Yeah.
that's when we get people saying, I really enjoyed this episode, and the way you were quite honest. And
Mm.
I don't know why maybe people have a need to hear people being critical, or being humble, or talking about mistakes in that way, because we don't see that a lot. We tend to hear the congratulations. People publish case reports about really interesting stuff they did well. People self-aggrandize on social media platforms and say, I'm so happy to be awarded this position, I'm so happy to have done this exam. We tend to present positive aspects of ourselves. So maybe people do seek out more, and they resonate more when people say, wow, listen to what I did the other day and how I learned from it, because it's a more unusual viewpoint in clinical medicine and in education.
Yeah, I completely agree. When we started this and started talking about our mistakes, we did get a lot of feedback to say it's very unusual to hear people talking about mistakes, but it's really helpful. Um, but also, I think some people listen to it or have maybe not listened to it anymore and think they're not very good doctors then because they make mistakes. And I've had some people
Yeah.
say, well, I don't make mistakes. I'm like, wow, that's amazing. I make them every day.
Yeah.
Or decisions
And
that I'm not happy with potentially.
we don't want people to listen and say, God, what a couple of clowns Amy and Ben are. I never, never get admitted to their hospital. Listen to the mistakes they make. So hopefully we got a decent split of the good and
Yeah. Yeah, no, I can assure you we are fully trained and accredited. Um, but yeah, thank you so much, Ben.
yeah.
Huge food for thought there. A lot of discussion about that anchoring bias, that first bit of information that we latched onto and just went down the cardiac road again rather than thinking. And it's about how the patients are sold to us, isn't it?
And I'll put a nice little button on the whole story. That patient went to surgery the next morning,
Okay.
and did fantastically well. I don't know what the surgeons did, because it's none of my business. In my mind, it's like untwisting a balloon animal or something, but they untwisted whatever was blocked, and the patient was discharged and traveled back to Lithuania after a few days, having been treated. So very positive outcome there.
Yeah.
And it's always
Yeah.
quite nice to make a surgical diagnosis as a medical.
Yes.
It's like, oh, still got it. Wow.
Yeah, and we get quite a lot of surgical patients, I think, through the medical take now because it was so busy that obviously we are going to see some surgical patients. And you're absolutely right. Actually, it's quite nice to make that surgical diagnosis.
Yeah.
It doesn't happen very often, but when it does, it feels pretty good. Yeah.
It does. So I wanted to give you a little happy ending there. So I guess the take home from this is thinking about, if you're a consultant, how you receive data and how you formulate diagnoses, and if you're someone who presents cases to other people, but how you present that data. And it's better, I think, to explain how you arrived at your diagnosis rather than give a diagnosis and then give the supporting evidence that towards that, because we tend to use confirmation bias and choose the evidence which supports our diagnosis and maybe just brush under the rug the bits that don't fit. Let's work through it together and then see if we come to the same one. And I think that's a more enjoyable experience as well as
Yeah,
a clinician. Brilliant.
absolutely.
Thank you so much, Amy, for listening
My
to my.
pleasure.
And thanks to everyone for listening. We love, love, love it when people send us any emails or messages on social media saying that what they liked, or maybe what you'd like to hear in a future episode. So we always reply. So please do send in any feedback that you have. And please let other people know that this podcast exists and that you like it. That'd be fantastic. Thank you very much, Amy, and I shall see you again next episode.
Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks